My name is Balana and I'm the Injury Prevention Officer for Workforce Engagement here at Injury Matters. Before we begin, please let me acknowledge the Whadjuk Noongar people, who are the traditional custodians of the land on which Injury Matters work, and recognise Aboriginal and Torres Strait Islander peoples' continuing connection to the land, waters and community across Western Australia and Australia. I would also like to acknowledge the traditional custodians of the land on which you are joining from. Come on, computer. Before we start, I would like to go over a few housekeeping points. Please make sure your microphone is muted. This will allow all attendees to hear clearly. We would love to hear your questions, so we strongly encourage you to please send them through the chat box throughout the presentation and we'll go through them at the end. If you have more than one person in the room with you listening to today's webinar, we would appreciate it if you could please let us know via the chat tab to let us know how many people are in with you. If you face any technical issues during the presentation, please write them in the chat box and we'll do our best to help. I have Joe helping me here today. We will also have a QR code at the end of this presentation, so you can complete a short evaluation on this webinar. If you could keep that in the back of your mind, that would be great. Please note that Injury Matters prohibits the use of artificial intelligence-driven systems and technologies, such as automated note-taking, recording, or transcription tools during or following this webinar. So, just about Injury Matters. At Injury Matters, our vision is for safer people and places. We aim to prevent and reduce the impact of injury within the Western Australian community and support those who have been affected by injury. Our 3 programs aim to raise awareness of injury risks, consequences and solutions, prevent injury through a range of education and support programs, and support the recovery of people and family and communities impacted by injury and trauma. This training is brought to you through our Stay on Your Feet program with the support of the WA Department of Health. The Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults on how to prevent falls in the community. Stay on Your Feet has 3 key messages that we use throughout our campaigns and community and workforce engagement. These 3 messages are move your body, improve your health and remove hazards. And this is where we get our overarching slogan, move, improve, remove. Falls are a significant public health issue in WA. It is seen that 1 in 3 people over the age of 65 fall each year. The 2024 WA Falls Report highlights that in WA someone dies every 17 hours, is hospitalised every 16 minutes, and presents to the emergency department every 12 minutes due to a falls-related incident. Falls can result in a real impact on an individual's life that can lead to a loss of independence and confidence, increased concerns of falling, and difficulty doing daily tasks. Older adults with dementia are at a high risk group for falls. Cognitive ability is vital in aiding alertness, planning movements, and responding to falls hazards inside and outside of the home environment. This leads me to introduce our speaker, Nick Seemann from Dementia Training Australia. Nick Seemann is an architect and area specialist in designing and supporting aging and dementia. As the environment specialist at Dementia Training Australia, he leads national initiatives to develop and implement workforce training to create more supportive environments in aged care homes. As Managing Director of Constructive Dialogue Architects, Nick oversees a firm that focuses on aged care, remote Aboriginal health, and social services. His work includes new building developments, renovations, and strategic review of care home infrastructure. He is also a lead author of the National Aged Care Design Principles and Guidelines for the Department of Health and Aged Care. Nick is committed to improving the built environment in aged care and health services, working on projects that enhance care outcomes and workforce capabilities. I will now pass you on to Nick.
Thank you very much. Now I'm going to try and share my screen now. Let's just check that that works. And I think that that screen's now up and running. Okay. It's a really nice group of people here in terms of, it's a large number of people. It's wonderful to be here as part of something for for injury matters. I think the slogan of move, improve, and remove is very relevant to what we're going to be talking about today. I am going to also just change the slide to the next one, and I'm going to acknowledge that I'm coming here from Sydney and pay my respects to the Gadigal clan of the Eora Nation. I think from my work, through my life working with older people, I think it's great that we in Australia do actually acknowledge the contributions and the important place that elders play in our world. And so I really enjoy saying that at the beginning. We have got a chat function here, and through the talk, I'm going to try and find ways of engaging with you. Do put in any questions that come up along the way. I think often we get to the end of a session like this and say, are there any questions? And at that point, everyone's put on the spot and it's hard to generate questions. So if anything I say brings up something that a question for you, please put it into the chat function. And if I miss it, then Bilana or one of the other people will bring it up later. If there are things you're interested in that relate to the references that I'm relating to in the work that in what I present, I'll send out some links to references, but also feel free to reach out and tell me that there's something more that you wanted to know about, and I'll send that. I can send that through. I'm going to go through my presentation for about 40 minutes. And then there'll be time for any questions or any other comments there. And along the way, I'm going to try and do things that are a little bit engaging in terms of how we talk about stuff. I'm going to start by saying a few of the things that led me to be interested in this area, which goes back to about 30 years ago when my grandmother was living in aged care and I was an architecture student, and I was looking at what was I going to do at the end of my architecture program to think through research. I went and spent time with a dozen older people in the community and looked at how they'd changed the physical environment around them as they got older. What had they done to make the building support them, and what were the challenges and barriers they faced? And that's been something I've stayed with through my life. And I've watched as various different people have in different settings had challenges that limited or supported them as they got older. The last remaining cousin of my father, I watched when he moved into a care home a couple of years ago, and small things like a very small step going out onto a terrace or out onto a balcony meant that he didn't go outside. I've looked at other older people like my mother or father and how they related to noise and how they related to dealing with changes to their hearing and how that affected their ability to engage or navigate an environment. And I think those experiences that we have of looking around at the people around us are what really influences how we see the world and how we relate to the experiences of aging. I think often we look at the environment and don't see it as being as central to the experiences we have. So through today, I'm going to talk about environment as, when I use that term, I'm talking about the buildings that we're in, the gardens, the light, the noise, even the social life are all part of looking at that environment. The main way in which, when we start talking about falls, that I look at the issues that relate to falls, is environments which are enabling environments are fundamentally important because they reduce the likelihood of falls. I'll come back to that. So there's two things I'm going to cover today. One of them is I'm going to talk about frailty, dementia, and the environment and how that relates to falls. And then I'm going to focus in more specifically on a piece of work that I have been doing with the Department of Health and Aged Care in the Commonwealth, which was principles and guidelines that were built around residential aged care homes. Now, even though I know a lot of the people who are here today are not relating to aged care, I like to start off by looking at aged care because it's the point where people are often the most vulnerable and the most in need of a supportive environment. And so it's good for us to look at what we want to do in care homes, but much of what I talk about is applicable to a wider range of settings. Somebody's asked, will the presentations be available after the session? Yes, I'm very comfortable to make the slides available. So I'm going to go through what we looked at with the principles and guidelines regarding residential aged care homes, but you'll see as I go into it, it has got a much wider application, an application to other areas like hospitals where there's a high prevalence of people with frailties and dementia, but also relevant to people's homes, which is where I started this. I've got three different things I'd like to do at the beginning, just to get everybody engaged and going. And the first one is I've got a small pub quiz. It's only got 3 questions to it, but just I've got some questions I'm going to put up here. In this instance, I'm not going to ask you to respond to the chat. I'm going to ask you to just think about your answer to each of these questions, just as a way of us warming up to the sorts of stuff that we're going to focus on. So the first one is a question there that's on your screen that says, what proportion of older adults are dealing with 2 or more chronic conditions? So have a think about what that might mean, and just as a way of us thinking about the people who I'm going to talk about today, older Australians. So what proportion of older adults are dealing with 2 or more chronic conditions? Is it 37%, 45%, or 50%? So lock in your answer, and I'll see what the next slide says, and it says 50%. And what this is really saying is, and you can see from that chart on the right, is that, okay, we've got people putting in 50%. There's 130 people here at the moment, or 130 viewers. So I am going to ask you to put in entries to the chat, but not yet, and not for the pub quiz. So you can see the chart that's on the right, chart 4 and 5 there, that are talking about as we get older, we've got a higher likelihood of sensory and physical challenges. It means my hearing is not as good as it was when I was younger. My sight is not as good as the sight of my kids. My cognition, that second graph, the lower one, is not functioning in the same way as it was in the past, and it will change more in the future. So just being aware that even healthy aging will result in sensory change, in physical change, in cognitive change. And then we can talk about something like where dementia fits into that, which is a specific set of conditions that are on top of that burden from healthy aging. So our next quiz here says, our next quiz question, how much extra light does a 90-year-old need compared to a 10-year-old to see equivalently? So have a think about that. A 10-year-old child needs a certain amount of light to make out the environment that they're in. By the time you get to my age, it's different because my eye is changing. It's changing from a whole range of things, and older person, it's even more the case. So again, have a look at it. Is it 50% extra light, 200%, or 400%? Okay, and people are thinking it through. I'll go to the next one. The next slide's showing it's 400%. It's 4 times the light. So you can see from that chart over on the right there that the light, it's going through different wavelengths in the chart, but the light that you need at the age of 10, especially in that sort of orange, yellow, red spectrum, for the amount of light a 10-year-old needs, a 95-year-old is needing 4 or 5 times the light in order to actually see the same. They need twice as much light to have the same experience that the younger person has. And often this is in your work, whether it's somebody who's working in a care home or somebody who, basically, if your work is going into somebody's house and you're a 30-year-old care worker or whatever it is that you're doing, and you go into somebody's house and they're 85 years old, the way that you're experiencing that environment is quite different to the way that they're experiencing it. And our third question in the pub quiz is, dementia is an umbrella term used to describe a range of conditions my grammar's failed me here, but a range of conditions, which of the following, it affects which of the following is what I'm trying to say here. So when we use the term dementia, it's an umbrella term. What does it affect? Does it affect A, our memory, B, our senses, or C, our planning, organisation and problem solving skills? And Fiona has very correctly said D, all of the above. If you are paying attention to the 3 questions, the last answer was always the correct one in this instance. But what I was just trying to look at here was, where does dementia come into all of what we're looking at? We know things like in care homes, half the residents of care homes will have a diagnosis of dementia. But if we go beyond that, we're looking at the fact that by the age on this, the information I put in front of you here, by the age of 90, 2 in 5 Australians will have a diagnosis of dementia. And when somebody's 65, it's 1 in 12. So in terms of the prevalence of dementia, it's high. It's a very generalised, it's a general term that does cover Alzheimer's, Lewy body dementia, frontotemporal dementia. There's more people talk about to do with dementias caused by sport injuries and other issues that have vascular dementia, where there are modifiable factors. There's a number of talks that I've looked at which say this all seems like gloom and doom, but there are things that we can do that reduce our likelihood of getting a dementia. So in early or midlife, things like a healthy diet, exercise, like having less, looking into any hearing loss and attending to it. There are a number of different things we can do that will affect it, but dementia is a very real thing when we're looking at older people. So as I said, there are 3 things I'm doing just to warm us up. The first one is looking at these sorts of issues as an introduction. The next one is something where we're going to look at a couple of slides. And so this time I am going to ask you to type a few things in here. Not everybody needs to, but the question I'm asking looking at this scene is, if you imagine yourself in this scene, do you like it? Do you not like it? And why? And if people think about the answer and a couple of people want to put something in there, that would be great. So just looking at this scene, if you imagine yourself magically transported from wherever in the world you are to this scene, is it a nice experience sitting here? Do you like it? Do you not like it? Why? Okay. And so people are starting to type some things in. Some people are saying they don't like it, that it's cluttered and they don't like the circulation. Somebody said that it's pretty but busy, and somebody else is talking about there being a lot of obstacles. Somebody said it's warm and inviting. Okay, and I'm going to move on to the next scene. So keep thinking about that one. And if we look at this scene over here, and the same question, this scene looks like it's somewhere in Europe, maybe Portugal or Spain. If you imagine yourself being in this scene, do you like it? Do you not like it? And why? And it's you as yourself. So I'm just saying, if you, as you are today, were suddenly transported to here, do you like it? Do you not like it? Why? And people are thinking that through. And I'm now going to actually go back to earlier. So as I said, this is a fairly quick exercise. If you imagine this was the older version of you at the age of maybe 85 or 90, do you like sitting here or not? And so if you imagine that older version of yourself, do you like it? Do you not like it? And why? And again, you get the general idea of what we're looking at. If we move to this scene here, if it's the older version. So I've asked you 4 questions. What was the experience of the first scene like in your current state? And when you project forward, what's it like? What's the second scene like, this one here, as you currently are? And what's it like as you think of your future self? So thinking all of that through. People put different things in here. And interestingly, a number of people didn't like the first scene. I think both these scenes at different times, I've personally found enjoyable. So I look at these and go, the first scene in the cafe, some people felt it was too cluttered or they didn't like it. I look at it, I kind of like it. I look at things that I might want to change. So if I go back to here, I'm looking, going, maybe those chairs aren't that comfortable. I was showing these to some people yesterday and they were saying the chairs look really uncomfortable. And so I can see that. But that's something we could easily change. And so a lot of what I look at in my work is, where are the problems in an environment, in places that we just go, and where are the good things? I like a cup of coffee in the morning. I look at this and go, I can imagine having a cup of coffee. If it's too cluttered, I can remove the clutter. Often we don't want to. If it's too noisy, I can look at things that will reduce the noise if I'm in control of the space. If it's a place that has things that I like the sunlight, I can probably adjust it a bit. It's a cafe. I can talk to the cafe owner about things like, can you move that umbrella? So what's working here and what isn't? If I'm somebody managing a space, like this is a hospital, a care home, or some other environment, and I look at it and go, I think that there are obstacles there. I think that the pathways are too narrow. What are the things that I can do that will actually change that? So the questions are asking us not just to look at what we do like or don't like, but what we can change and how difficult it is. Even more the case here, I look at this space and some of the questions about it, some of the comments are positive. Mostly people look at it and say, it's really noisy and cluttered. And I look at a space like this and go, when I was 20, fantastic. Now, even with my hearing as it is, I sometimes find a space like this a bit much. Some people use terms like claustrophobic or difficult. I show these images to people and half the time people really like it for their current self. But once we project forward to an older version of ourselves, it starts to become more problematic. So we look at something like this and go, if I'm an older person sitting here, I'm going to have a harder time being part of the conversation because I'm having more difficulty filtering the background noise. If I'm in an environment like this and I want to get up, it's crowded. How will I cope with getting up? if I need to do something quickly, like go to the loo, what are the chances I can do that? So I'm looking at spaces like this that, it's from a place of people doing a photograph and saying, isn't this great? And in some contexts it is, but as we get older, this is more and more challenging. And so that brings me to the issues that I want to go through here. With both of these, I'm bringing up what happens as we get older, what happens to our senses, what happens to our ability to move around the place, what happens if we have a dementia or other things that give us other burdens. And for me, I'm seeing that I already have various impairments. I wear glasses, so I often deal with my vision impairment by wearing glasses. In terms of if I have difficulty with noise, I'll often try and find a quieter space to go. So I find ways of dealing with it. And so we have various things that we bring into the world already at my age, definitely as somebody's older, which I would term impairments. When we use the term disability, I'm putting forward an idea that disability is something which is environmentally a product of the environment. So if my impairment is being dealt with like my sight impairment, then that means that the environment isn't actually being a problem. If the noise of the environment is making it unable for me to cope, like potentially in the scene in front of you, then the environment is actually making it more difficult and the environment is disabling. If the environment makes it harder for me to get around because I can walk, but I'm being asked to walk a long distance or I'm being asked to deal with a lot of obstacles, then the environment is causing disability. And what I'd like to do now is just step across into where falls comes into this for a bit, and then focus a bit more on the principles and guidelines in a second. Okay, so I've just jumped to another slide. I'm having one slight technical thing here. I hope that still is sharing properly there. I think something just went wrong. I'll go from the current slide. Okay, so I'm just fiddling a few things because I lost my okay, I'm back now. I've got everything back now. I just had a loss to my Q&A for a second there. And as we go, please do continue to put any questions or comments in. But those two exercises, I'm going to skip the third exercise because I think that there are issues that we can come back to later. But people's responses there were great. And so that's starting for us to look at why is this so significant. When we look at falls and focus in on what I'm going to talk about relating to falls, for people who are older, people with a diagnosis of dementia, or people in nursing home, these will all contribute to higher likelihood of falls, and the risks become really high. So without going into the specific statistics, and I can provide them, the likelihood that somebody doesn't recover from a fall and it leads to a downward spiral is very high. So I fall, I move into a hospital or into a care environment from which I never fully recover. And so that's not that's a high risk. It's something like a third of falls people will not fully recover from beyond an age of 85 of a serious fall. And I can go through the exact statistics, but it's of that sort of level. And so falls become a very significant thing in terms of once we're talking about an older cohort of people. The environment is a key element that when we're looking at risk. So when you go through a literature review and you say, what are the factors that lead to falls? Things that will come up will be a history of falls, people's gait, balance and mobility impairments, visual and cognitive impairment. So the things that we're talking about, fear of falling, environmental hazards, muscle weakness, incontinence, and poor footwear. All of these come up as things which will contribute to falls. Now, the interesting thing about us relating to falls is I can talk about reducing hazards, perception of the environment, active lifestyle, personal agency, which relates a bit to where we started with move, improve, and remove. So I can relate to that. And while that's what I'm going to focus on for the rest of the talk. How do we relate to that? When you look at cross-disciplinary reviews of falls, it's hard to find clear evidence that even says, oh, falls are caused by the environment. So I'm just making it clear here that all the times that I've gone through and done reviews of the literature, people will go through what are the things that contribute to falls, and often will have difficulty even pinning it down to the environment. And I'm saying that's a failure of the research process rather than the reality. When people present with a fall, they're often falling over something, and the environment comes into that. How we deal with things like the surface somebody's walking upon, is an issue. How we deal with a high likelihood of people being able to see their way around are the issues that we know contribute to falls. And I'm just flagging the fact there and acknowledging that the research is hard, but I'm working with the basis of there is a logic here that I can build off, and there's a reality of the lived experience of people who I've worked with. So going through here, what can we do when we work with older people? We can look for hazards. So hazards in the environment might be very small changes of level. We can look for better perception of the environment. I can find my way around, and we can encourage people to remain active and remain more independent in control of what they're doing, more comfortable in the environment they're in. And I'll just give an example of the sorts of things that we can look at before I go into in a more structured way into how we relate it to the principles and guidelines. If I look at this staircase, at the moment, what's being highlighted, it's similar colours around there. Can I find my way around the staircase? I'm going to talk a bit about tonal contrast. If I look at the tones are very similar. If I want to highlight something, if I change even the colour to a strong white on the side of the stair, it's easier for me to see the stair. So that model of what I'm trying to do going through this here, I'm going to come back to again and again, which is if we look at an environment through a certain lens, in this case, by looking for the tone, we can do simple things that make it easier for me to find my way around, and that's an enabling environment. It's helping me deal with my impairments to reduce the level to which the environment is disabling me. Somebody's asked about the reporting of falls in nursing homes compared to people living in the community. I don't know the answer to that. It's a good question. I think that in care homes, the reason why I often start with care homes, like it segues into what I'm about to say, is that care homes are settings which have the highest likelihood of somebody coming with a range of frailties and cognitive impairments. And it's an environment where there is the greatest intensity of supporting that person. So it is not a snapshot of the community, but the issues that I'm going to go through relate to both care environments and wider environments. So I'm going to now move into talking about this project that I worked in, which was the National Aged Care Principles and Guidelines. Coming out of the Royal Commission into aged care, one of the recommendations was there should be national guidelines about design. And the department approached DTA, who put me forward to work with the department on as a key author developing these. So I haven't really introduced myself more fully. Thank you for the introduction before. I'm an architect. I do work in developing buildings, primarily in remote Aboriginal health and in residential aged care. The work that I do led to my involvement through the University of Wollongong in Dementia Training Australia, working on a national workforce training program funded by the Department of Health and Aged Care. And as a funded organisation, there's a whole range of things that we have resources and programs that I'll come back to, and I'll send resources or links to coming out of this, where there are various free programs that go through how do we understand creative environments, how do we deal with a whole range of issues that come up both within aged care homes as well as other wider issues that relate to these same issues. There's programs that relate to GP support for understanding dementia and dealing with it, this range of things. I fit in as the environment specialist within DTA, and within that remit worked on this particular document. The background that I have goes back to work of Paul Folleros, who was an architect who worked primarily in remote Aboriginal health and looking at how houses worked and how houses could be supportive to health outcomes. What you're seeing there, and I'm just touching upon it briefly, there's a great TED talk in which Paul goes through his work. Paul worked across decades to improve health through design, and his team worked to do maintenance work and fix projects in houses across the country. Paul was, I believe, personally responsible for, through his work, over 7,000 homes being fixed. And by fixed, it meant there were better health outcomes, there were less hospitalisations from like 10-year longitudinal studies of the work. Paul's work came back to looking for healthy living practices, how we could affect health with the physical environment. And what you're seeing in those diagrams on the left is the top square showing kids being washed, or kids being able to be washed. Then you've got clothes being washed, and then you've got waste getting away from houses. And so he focused on how can we set up buildings that actually have these health outcomes. I took that work very strongly as a basis for what we started to look at when we looked at what can we do to make aged care environments and aged care home environments and wider environments supportive. And so that really informed the work that we did. When we started looking at what we wanted to put into a set of national principles and guidelines, we developed 4 principles. The work that we were doing here built on decades of work by people like Mary Marshall in Scotland, Margaret Calkins in America, and Richard Fleming and Kirsty Bennett in Australia, who'd been going through what can we do with the physical environment that can actually have an effect, an impact on people's lives. And their work goes back through work from the late 90s that articulated what were the things and started to build on that research base. What we took from that was how can we identify what are 4 key outcomes that the environment should help us achieve, what are the 4 biggest priorities, and to set a target. So the principles were a target of where we wanted to get to, and the guidelines that sit under them were how do we actually chart our way along that. Somebody's asked for the TED Talk. I'll send through a link to that. These 4, the first one was enabling the person. The first one is really about what do we do in the same way that we want buildings to be wheelchair accessible. If we look at a whole series of cognitive and sensory and physical impairments that people might develop as they get older, what can the building do that helps to enable somebody to reduce the level of disability that is caused by the way the environment fits in with those impairments? In terms of aged care, we're focusing a lot on smaller scale environments, which was one of the recommendations of the Royal Commission. The third one was how do people get outdoors, which is a real problem in residential aged care where there's very poor access out to gardens once people move into care homes, and how do people stay? The fourth one connected to the community in terms of are people moving into a separated space, a ghetto away from the world, or do they maintain connections to their church, to the life that they've been living? So those 4 things will enable the person cultivating a home, accessing outdoors, connecting with the community. And we then looked at what can we do that will actually support somebody to achieve those 4 outcomes. So the guidelines, the principles and guidelines are made up of pages that look like this. And I'll unpack this a little bit further. But so one of them, which talks about tonal contrast, is in that first category of enabling environments. And to enable the person, I touched upon it before, tonal contrast. This is a really big issue. So what we're looking at here, and it's a consistent thing that comes up, is any environment that you're working in, to what extent does it make it easier for me to see? My eyes change as I get older, and we know that, say, the colour rendition is poorer as we get older, but if I can see clearly where a surface is changing, where a floor goes into a wall, or where objects fit within the environment that I'm in, I know that I'll function better, I'm less likely to fall. The reason that we've got the 2 pictures on the left, the colour and the black and white, is that we're saying the colour is a care home. If we take out the colour from it and use even just the monochrome filter on a smartphone to take out all colour, that's a clearer idea of how somebody sees an environment or can distinguish as they get older. So the colour's a bit more washed out, but what stays is if something is light or dark stays. So it's not relevant, am I mixing green and yellow or red and blue, but if I actually turn an image into a monochrome image, what am I seeing? And so the principle, that first principle, enabling environment, is made up of a whole series of elements like this. And again, going back to where does this come in, where do falls come into this? My starting point is if an environment is easier to move around, if I can maintain my perception of where I am, I'm less likely to fall. Each guideline has this structure. So you're seeing the pages from it there. It's saying the key thing here is achieving tonal contrast. It's about how can interior design support objects being easier to see. And then there's a description in the top right that says, how do we use contrasting tones to clarify key surfaces in a room? And I'm not going to read it out, but it goes through that. We'll also put a link to this book into the show notes or the whatever goes out after this talk. That first principle, enabling environment, is the one that I believe is the most universal. I think it's irrelevant whether we're talking about a care home. I think it's relevant if we're talking about going to a hospital, if we're talking about going to the dentist. It's relevant if you're talking about the entry to a club. All of these spaces that we're now very aware of wanting to make accessible to somebody who has more difficulty walking around, and how we use ramps. These are ways that we make a building more accessible generally to an older person. I think that anything we think of as being really nice interior design to make something look good, if I'm walking into a dental surgery and every finish is white, as an older person, that makes it harder for me to be able to find my way around. It makes it harder for me to distinguish between where is a wall, where is a floor. If I'm walking into a club and every surface is dark and the light levels are lower, these are things that make it harder for me to navigate the world and more likely to fall. Okay, so going to the next one, the same issue, in that same area of issues, we're talking about contrast so I can actually see my way around, and simple circulation so I can remember where I'm going. So we said if I can see my way around, well, that's a plus. If I can physically make my way around without tripping over something, that's a plus. And if I'm feeling comfortable where I am, I know where I'm going, I know how to get there in any environment, that works. Relevant to a care home, relevant to wider world. You're seeing over here different diagrams that show different circulation forms in a building. The one that involves a change of direction multiple times to go around that corridor, that's a harder one for us to remember where we are. The one which has only one change of direction is better. And the reality is, if our biggest focus is on somebody being able to find their way around, I want to, from wherever I am, stepping out of an office, out of my bedroom, wherever it is, I want to be able to see where I'm going. And you've got here a quote from Justine Marquardt, one of the researchers who focuses on these issues of shifts of direction being a real problem. Again, you've got the guideline that talks about changes of direction and talks about how do we make things easier and work with that. And there's a third one that I'm just going to focus on in terms of just starting off looking at those issues of what makes an environment enabling and easier to find my way around. We touched upon it before, but definitely high levels of lighting are important. So that means if I'm comfortable in a space that I can find my way around at the age of 25 and think this is a good level of light, it needs to be much higher for that to work for me as I get older. There's a reality that when we're outdoors, the levels of light are much higher. So you can find things on a phone which are simple lux meters, and if you want to work out is this good or bad, sometimes we need an external measurement to our own eyes to know whether we have a problem or whether this is working fine. And so I use a lux meter on my phone that was just a free download. I don't plug any particular one. If you look for that, you'll find things for measuring noise, things for measuring light, and the light levels that we might want for walking around. I mean, there's ways where you can find the numbers, and I can send through links to it. But even just walking through a corridor would be, working out ways of, is the light level around 300 lux or thereabouts, not a darker level of light. When I go through here, these are the 31 guidelines that sit underneath the principles, and you can see that top row are all those things that I'm saying are actually just about how we find our way around. If there's clutter, I'm more likely to have things I trip over. If there's noise, I'm more likely to be overwhelmed by the noise as I get older and have a harder time filtering. If the lighting's better, I can see things. I touched on tonal contrast, simple circulation, and safe floors. If there is a single tone to the floor and there aren't changes of level, I can get my way around. If it's wide enough that I don't worry about tripping off the edge. If there's places to sit along that walkway, I'm more likely to rest when I need to. And we can also talk about things like people getting to a toilet, or points of stress being times that I'm more likely to be stressed by what I'm seeing and therefore be susceptible to a fall. I'm going to go through the other three principles more quickly. They're more relevant to care environments, but again, I think they've got wider application when we look at falls and we look at people's comfort. The second principle talks about cultivating a home. We put two images there. They're very different care homes. One is one that's in the just south in the Southern Highlands, south of Sydney. The other one is in the north of South Australia. 2 care homes, different social needs, different environments. I just put that up there as an acknowledgement that a home means many different things to different people. When I look at this in regard to care homes, I'm looking at that's the same image. Harbiston was the first one you looked at. And when I look at these 2 homes, these are attempts to get smaller groups of people together. So in terms of thinking through what we think about as care home, a smaller environment, a care home, and I'll then extend to where I think this relates to other people's homes. The issues that we looked at were institutional environments that are big with lots of people are hard. They're harder to not make those environments noisy. They're harder in terms of a whole range of those issues that we looked at in that first principle. In terms of what are we aiming for, it's going to be places that people can personalise. This is again focusing on care homes, smaller households of 15 or less people living together, an entry which is the entry to my home, a kitchen where I can make a meal, smaller room clusters. If we look at these and expand them to a wider environment like somebody's own home, the questions to ask are things like 2.9, is the furniture appropriate? It might be that the chair was fine when I was younger, but right now I need a more stable chair to work with. If we're looking at things like social activity that people are used to, even though somebody is social, they're less likely to be overwhelmed in smaller groups as they get older, and these are realities. So a lot of these are how do we maintain a home environment that's functional and is still achieving the things that we want. The stuff which I learned from the very beginning of me being interested in this area back over 30 years ago when I visited those 12 people was as they got older, people tended to spend more time in the same place. What that meant was, before mobile phones, what that meant was the older people were more likely to find a comfortable chair in a spot where they could watch television. At that point, they would have a telephone that was nearby, and there would be somewhere to go to the bathroom and a kitchen really nearby, and ideally a view of their front door and outside. So how are we changing the environment as we get older? How are we shaping it around us? What are we doing that still keeps that sense of home? So we could completely declutter an environment and get rid of everything and leave us lost because those things that we want are not actually clutter. They're really about us finding a sense of who we are in our own home. So in that sense, this bit of the book is built around care homes, but there are messages there for how we deal with making somebody's own home continue to function as they get older. The next set of guidelines was under a principle that looked at getting out to gardens. And as I mentioned right at the beginning, one of the real problems moving into care homes is that many people just never get out. Once they move into a care home, they don't go out to gardens. It's hard. It might be that a door is hard to get to open. It might be that the door is locked. There's all sorts of issues that people have. We know going outdoors is really important. It's important because it gives us fitness. It keeps us moving, going back to those original ideas. Access to daylight is good for bone density. It's good for my circadian rhythms. It's good for vitamin D development. Being outdoors, I think it's good for mental health. Different elements through that, I can actually point you to the research and what it says, and how each of those affects us and our likelihood to stay healthy, but also just that need to be able to go outdoors. When we look at going outdoors, in a care environment, we're saying there's a dedicated outdoor space. There's a good connection. I can see the outdoor space. There are verandas where my eye can adjust as I sit on a veranda going outdoors. In that garden, there is a place that I can go and do things, and there's a pathway back. So again, this is written for a care home, but applicable to other environments. It's applicable if I'm thinking about getting outdoors at my own home or when I'm going to a public space. What are the things that help me to move between inside and outdoor spaces so I do get that exercise, I do get that joy of going outside? Different care environments in terms of the other images I've got here show there are environments that really focus on how we can get outdoors. I think if there were more places like hospitals or other communal spaces that looked more like this, that would make me happier. So going back to that, what I've run through are those first 3 of the principles. The 4th one is all about how do we stay connected to the community when people move into a care home, and I'm not going to unpack that one today. But that's mainly going through what are the things that we can actually look at that start to impact upon our ability to stay on our feet. and make it easier for us to get around. So those main things that I was looking at were how do we manage to navigate an environment better? How can we, if we're somebody working in an environment, somebody's home or a care environment, how do we look for things that we can improve? And how do we then focus on making those changes that make somebody's life work better, and it makes it less likely for them to fall. And I'm just going to finish on just putting up this last slide here, which is just a link to the principles and guidelines, as well as a link to a course that we developed that goes through many of these issues. And this is a general again plug for the fact that Dementia Training Australia provides programs which are largely free programs or small fee for service. If you're in an environment like a care environment or some other situation where you have a team that you want to get more aware of what you can do to make an environment work better for an older group of people, we run programs that can support you. And there's other tools that we have that will help you to audit an environment or to look at an environment to understand it. So what you've got here is a link to the principles and guidelines, a link to one of our courses, and we'll send out other links that actually go to other resources that the DTA provides. So that gets to the end of the presentation. I'm not sure if I missed some of the questions there, but now's a good time that if you do have questions, please send them through and I'll see what I can do to answer them. I'm going to stop sharing the screen. And at the moment, okay, the first questions come through, which was any methods that we're using to reach out to better educate OTs, health professionals in community settings. The programs we've got, there's two ways that we engage with people. We can engage with people through DTA that are one-on-one learning. And so there's pathways that we can set up for somebody's learning to go through a series of things that start to go through a better understanding, say, of dementia. So one of our programs is called Dementia Discovery and goes through different types of dementias to give people an understanding of that. There's programs through one of the partner organisations within DTA is Wickings down in Tasmania, who run an Understanding Dementia MOOC. So you go from the Dementia Discovery is a series of, like, it's probably a 2-hour commitment, whereas the MOOC would be a longer term process that you do over 9 or 10 weeks in order to have more of a deep dive into understanding dementia and seeing how you could apply that to your own environment. If you had a group of people and wanted us to engage with them, a group of OTs or health professionals working together, then that's something where we can also provide, do a discussion. I ran a program for 19 architects yesterday, talking through how this material related to the work that they were doing. So there are all sorts of opportunities. So if you reach out to us, we can go through what the different possibilities are. There's another question here, which is, as an OT, I do discuss things like this. It's hard to get people to change their environment in the home. Oh my God, if you suggest that they remove or replace a rug, the clients are attached to things. Look, this is the challenge. I'm very conscious of my role as a professional, is that I'm stepping into somebody else's space, whether it's their home or going into a care setting. I don't actually have any control. I can give advice, I can go through the pros and cons, but at that point, it's really up to them. So it's going through what I'm saying the research says. I'm saying these are real issues. I'm saying that with something like a rug, there is a risk of somebody tripping over the edge of that rug, and as a result, them going into a downward spiral of that fall being something they don't recover from. So really, how important is the rug? And on that level, it's really just that engagement. I think that for my work, it's all about how do we engage as somebody who is there giving information to the person who actually has agency to bring about change. Are there any funding services available to financially support families to make environmental changes as needed? My aged care does GAT, but they wouldn't change paint colours or anything like that. So the work that I do isn't focused on home modification in terms of actually bringing that about. I know there are programs and services out there that do it, but I can't list those or name them. How do you know how much colour contrast is required to assist wayfinding? Okay, so in colour, there's a thing called an LRV, which is actually a measure of that contrast. And so when you look at paint colours, you can look at what the LRV is of different paint colours or a different floor finish, and we've put in recommendations of what you actually want that contrast to be. So to create a contrast, say, of 30% is giving you a good contrast that you might want between a wall and a floor, whereas the floor, even continuing from the inside to the outside, you might want to keep really low. So we look at it and we'll look it up and say, we want the LRV to be like less than 10% or less than 5%, because at that point, we know that my eye is not misreading something as a step when the step isn't there. Somebody's asked about dignity of risk, which is a huge issue, especially in environments which are as controlling or controlled as aged care homes. And so dignity of risk, for people who aren't aware of it, is saying I can inform somebody of all the issues, but ultimately we're independent human beings and we have a right to be aware of the risks that we're taking to take those. And when people go through a lot of consumer surveys, dignity of risk comes up a lot, which is I want to maintain the ability that I have to, if I want to go skydiving, that's on me, not on you. And the same applies to the rope that somebody mentioned before.
Hi, Nick. I think there was just one question in the Q&A from Karen. How do you feel about falls and sensor mats in residence rooms?
Okay, so look, I think there are a lot of things like sensor mats where if there are ways of knowing somebody's looking at somebody's behaviour and looking for risk of fall, that's a really good thing to look at. Even like iPhones now will talk to you about it. Like I found a setting on my iPhone that talked about irregular gait and whether or not that was actually increasing the likelihood of me falling. And the same way, anything that tells me how often somebody's getting out of bed in a care home and whether or not their behaviour is consistent and they're doing it safely or is irregular helps me to manage that whole environment of, is this person's behaviour changing such that they're at risk of a fall and how do I engage with it? Somebody falling and being able to get there and deal with it with some form of sensor mat, or there are various different ways of doing sensors to tell us that somebody's fallen, I think is a good thing. I think that anything that helps us, not even just in a care environment, but in other situations, to know that somebody has fallen and then help can be provided, I think is important. And then often in care environments, it's about the cost of different systems in terms of it being an affordable thing. But there's a whole range of different things that we can do. I think to monitor what is actually a change of behaviour that increases the risk of fall is good. I think to know when somebody has fallen is really good.
Okay, thank you. And I think we'll just have that last question from Linda and then maybe move on.
Okay, so the last question was, when there's a lack of funding to make floor surface changes, do you have practical suggestions to support a person who struggles with floor surface colour changes? So in something like in a care environment, I know this is not where this question I think is focused on, but in a care environment, my commentary or my discussion with providers is usually at some point you are going to go through upgrading interiors. Let's make sure that when you do it and you're spending the money anyway, you get it right. And so rather than focusing on a fancy, nice looking finish, are you getting these things right in terms of tone and contrast? There definitely are programs out there that support people in the community in their own homes. I don't know so much about those, and so I don't really have practical suggestions on that level. But I know the things that don't cost anything are removing clutter, actually getting rid of rugs, doing things which look for areas where it's not light enough and actually increase the light. Anything which reduces noise and therefore makes it easier for me to focus. Many of these things are not expensive. It's actually about working with a family in order to bring about a change that actually makes somebody's life safer.
Okay, great. Thank you all for those questions. And thank you, Nick, for that really engaging presentation. I really enjoyed that you showed different examples and included the audience in that presentation. I would now like to go through our Stay on Your Feet program and how you can be involved. So we have a suite of resources that you can use in your workplace or with your clients. If you head to our Injury Matters website, you can find all of our resources available, which you can download and print off for free. We also offer 2 free self-paced online learning modules, the Introduction to Falls Prevention and Exercise Strategies and Screening for Falls Prevention. These online modules provide professionals with background knowledge of falls, age-related changes, and how these can impact an individual's function, mobility, and falls risk. These modules will help you facilitate falls prevention exercise strategies for older adults as well. I would now also like to highlight the upcoming events that we have planned. On the 18th of June, we have the Building Trust and Engaging Multicultural Communities in Injury Prevention Programs and Services webinar. This webinar will look into practical tips for effective communication and engagement, the importance of partnerships and collaborations, and we'll look at a case study of a multicultural injury prevention program. And on the 25th of June, we have our Active Balance for Falls Prevention workshop. This workshop focuses on the importance of balance in falls prevention and will explore recommended falls prevention exercise strategies and how to implement them. You can register and read more about these events on our events page. The Injury Prevention Summit is a one-day event held every 2 years by Injury Matters through the No Injury program with funding from the WA Department of Health. The summit will bring together injury prevention and safety promotion practitioners, policymakers, and representatives from local governments across Western Australia to share knowledge and strengthen their capacity to integrate injury prevention and safety promotion into their work. The summit will be held on the 12th of June with the theme The Future of Injury Prevention. You can read more about the summit and register by scanning the QR code. Thank you again for taking the time to tune into today's webinar and to Nick for sharing this information. Please connect with us. We're on various social channels. You can also sign up for our Falls Prevention newsletter and our Community Falls Network. Have a great afternoon all, and thank you again, Nick.